Thank you all so much. So we have set the historical perspective. We've looked at the impacts of the RBRVS system on primary care. Now we're going to discuss solutions. And we have an outstanding panel of experts representing a variety of views and opinions and perspectives to do that. So I'm going to introduce our moderator for this session, Kristen McGovern from Sirona Strategies, and have her come up, and we'll welcome the panel to come up right behind her, and we will get started. Kristen.
All right, well, as Sean said, we are delighted to be here to talk about some solutions today. I think to kick things off for this third panel, we are going to have all of the panelists introduce themselves. As Sean mentioned, our panelists today bring a variety of perspectives on primary care to the table, and so we are hoping for a very well-rounded discussion, but to sort of set the stage, I think it's important for you to know who we have here. So I will start with Dr. Krist.
I appreciate being here today. My name's Alex Krist. I'm a family physician. I teach and practice at the Fairfax Family Practice Residency. Been there 30 years and trained about 300 family physicians. I also do research and direct our state's primary care practice-based research network, and we know every primary care clinician in practice in Virginia. And I had the opportunity to serve on the Implementing High Quality Primary Care Report, and I'm on the Standing Committee for Primary Care now.
Hi, my name is Purva. Rawal. I'm the former Chief Strategy Officer at the Innovation Center. That was my most recent position. I'm a psychologist by training, spent time in the Senate, worked on the Affordable Care Act, and then spent a long time prior to being in CMMI in kind of business strategy and policy consulting and teaching, and I've been in the value-based payment space and primary care space for many years.
Great.
Hi, everyone. My name is Miriam. I'm on the faculty at Columbia University. I study physician payment, and I've done a lot of work in that area over the years. I've also done some work on private equity and investments, serving currently on a work group at the National Academy of Medicine, and was a health policy legislative fellow in Senator Warren's office last year here in DC. So thanks for inviting me.
Great. Dr. Silva.
Yeah, thanks for having me. My name is Ezequiel Silva. I am in private practice. I am an interventional radiologist in San Antonio, Texas. I have a number of jobs that I very much enjoy, and one of my favorites is why I'm here today. I am the chair of the AMA Specialty Society RVS Update Committee, also known as the RUC. Thank you.
Great. So as you can hear, range of perspectives, practicing family medicine, practicing specialist, someone who set payment policy, someone who studies payment policy. So we're really bringing a range of different perspectives here. I think in thinking about innovative solutions to some of our primary care payment challenges, we first wanted to set the landscape. So we heard a little bit from Mark and Purva about the RUC and RBRVUs, probably getting the acronym mixed up here in this afternoon, but we thought we'd set the stage by having Dr. Silva talk a little bit about the RUC, their role in setting payment policy, and what they do, what they don't do, clear up misconceptions, or create them as it may be, I don't know, but set the stage a little bit with some discussion about the RUC.
Again, it's such an honor to be here to talk about the RUC, especially during innovative discussion like we're having today. I'm going to be frank, I believe in the RUC. I believe in the role of practicing physicians engaged in informing what it takes for physicians and other professionals to do what they do. Come right out the gate and I'm say that I've been engaged with the RUC since about 2008, among my other responsibilities. It's very important to me that this group understands who the RUC is and sort of who we're not. So when we think about who we are 32 members. And I thought Dr. Bitton nicely summarized our history, nicely summarized our makeup. We're 32 members, 29 are voting. As stated, 20 or so are appointed by different specialty societies, and that goes back to the early 1990s. When we talk about the RBRVS, it kind of rolls off our tongue, right? RBRVS. But if you think about what the acronyms are, we really are focused on the first R, which is the resources. It is a resource-based relative value scale. So we bring experts together, physicians in practice, professionals, and we inform the resources which are required for physicians to do what they do. Sometimes, to be fair, that is a procedure. Sometimes that is very technical aspects. Sometimes it's what are sort of generically referred to as cognitive activities. But we bring those together and we inform what those resources are. Here's what we're not. Once we formulate those resource recommendations, we inform the relativity recommendation, everything that happens after that is not specifically in our control. And we there's a causation challenge here where oftentimes we're attributed some of the potential shortcomings which may occur downstream. We don't even control the exact payment amount. We don't control the conversion factor. We don't control contracted rates. We don't even control coverage determinations. And we certainly don't determine salaries based on any individual physician, any individual specialty, or any individual institution. The first speaker mentioned that during the evaluation process that we don't evaluate outcomes or that we don't evaluate other parameters that might inform relativity. I just want to be clear, our job is to inform the resources to inform that position on that scale. What happens before, prior authorization, et cetera, what happens after matters. I'm not going to minimize that for a second. It's just we don't specifically and directly control that. And I want to close, there's sort of two, and I really want this to be a positive discussion because at the AMA we are 100% committed to all of our physicians. We have 270,000 physician members across the entire House of Medicine. We're committed to every physician being able to do what they do as well as they're able. But the criticisms I sometimes hear is, number one, is this bias discussion or this conflict of interest discussion. Our members are independent. Just like as a panel we're independent, our members come to the table, they make decisions independently. In fact, they're not even allowed to speak to their specialty or to speak to any tab that relates to what they're doing. And then number two, and I'll close, time is one of the elements we use to inform, but every time I read a criticism in the literature to the RUC, it always focuses, in my opinion, overly so on time. Time matters, but also magnitude estimation. You know, a level 5 E&M is just going to be valued higher than a level 4. That's just the nature of a relativity scale. Kristen, thank you, and I look forward to this discussion. Thank you again.
Great. So with that level setting, I think we'll move into some of the solutions and, the challenges, of course. So one of the challenges that has been talked about significantly in the primary care space is the workforce shortage. And we do often talk about, you have your workforce problems over here and you have your payment problems over here. And we sometimes talk about them as if these things are separate and disconnected from one another. But the reality is, of course, our healthcare system is all very interconnected, and what happens on this side impacts what happens on that side. So Dr. Krist, can you talk a little bit about how you see payment issues impacting workforce challenges and some potential solutions that you see around those issues?
Well, I'll start with saying, both the Implementing High Quality Primary Care Report and the Standing Committee began with looking at payment, because payment does have a big impact on workforce. And, it's interesting thinking and listening to the structuring about resources and figuring out RVUs. The Standing Committee said that primary care is the foundation of our healthcare system. I don't think we really understand the resources needed for the foundation of our healthcare system. I think that's a fundamental problem that we have, and we have to understand that. We have a big workforce shortage, as you said. So in Virginia, we've identified every primary care clinician. We're about 30% short of workforce if we want every person in Virginia to have a primary care clinician. And what's really scary to me is we have twice as many doctors over the age of 60, 30% of our workforce, as under the age or between the ages of 30 and 40, which is 11% of our primary care workforce. So it's going to get worse. There was a study in 2009 that showed that on the first day of medical school, half of people entering medical school had already ruled out primary care as a discipline. A lot of that has to do with the pay gap. So that's one of the causes of that. And so correcting that pay gap is important. And I suspect that that's gotten worse because the pay gap has gotten bigger and the debt of students has gotten bigger. But the other part that ties into that is that element of resourcing primary care. It's not about salaries necessary. It's about making sure we're valuing the foundation of our healthcare system and building the foundation of our healthcare system so that you can practice in an environment that's healthy. And burnout in primary care is very high right now. So that also contributes. A lot of our students and residents look at primary care and they're like, wow, you all have to do a lot of work. I don't want to do that. That's not for me. And to put a face on that, I had a patient yesterday come in for her annual wellness visit. Annual wellness visit, I got to do about 15 things already dictated by Medicare. But she said to me at the beginning of the visit, she's like, Doc, Did you look at the email I sent you? I've got 12 things I want to discuss today. That's 12 outside of the 15 that I have to do, outside of the 10 that my health system and EMR tells me I have to do.
Plus the time to read the email.
And the time to read the email. And you know what? I did it all. I did it all, and I did it all in 20 minutes because I've known her for 30 years, because I had an interprofessional team that included a nurse who could get everything started. I had a pharmacist who I could connect and do all this work afterwards, and other team members who had to help me with things. But that's what we need to be thinking about when we start saying, well, what's the resource that it takes to deliver primary care, and how do we value all of those people, all of those actions that are relatively random and chaotic and different for each person in every encounter.
So we brought up the dreaded email topic, but it dovetails into another challenge, which is that the work of primary care oftentimes occurs outside the visit. So coordinating with specialists, coordinating with the pharmacist, reading patient emails, communicating with patients. How do you think about that and some of the solutions, the challenge associated with that, but some of the solutions, and how would you think that payment should be adjusted to reflect some of that time that occurs outside that office visit?
We started the discussion today where people are talking about hybrid payment. And I think the implementing high quality primary care group thought very much about hybrid as just opposed to per member per month and other things like that. I started in the 90s in my practice, and we had pure managed care and HMO, and that didn't go very well. And interestingly, we've surveyed a lot of primary care clinicians as part of Medicaid expansion in Virginia and asked about value-based payments and their interest in that. And there's a lot of skepticism of it, a lot of belief that it was just a different way to pay people less. So some of the things that are important are being able to trust that it truly is an increased resource, that it's going to be stable, that you can count on it. You're not going to invest a lot and build teams and infrastructure and resource and then have it taken away from you. I do think a lot of the CMS's advanced primary care management payment and policy is a really good step forward with trying to get that hybrid type payment, recognizing fee-for-service is important, but let's come up with the per member per month for all the extra activities that we do and that we need people to keep doing.
I want to drill down on that for a second. So Dr. Silva, under a hybrid payment system, how would the RUC play a role? How would the values set by the RUC, would it just be a factor and then it's built into a broader payment structure, or how have you talked about it as part of your work?
Yeah, as I think about a hybrid model, I envision sort of a per patient per month added payment onto the fee-for-service piece. So our job is to make sure that fee-for-service piece is accurate, representative, and captures the work that's involved. I mean, I'll be frank, there are challenges with coordinated care as opposed to single individual services from a fee-for-service perspective. We've acknowledged that. We've worked on a number of coordination codes, transitional care management, chronic care management, even primary care management. And we know from experience, it's hard to capture all of the work. I mean, to Dr. Krist's point, to capture what we sort of call pajama time, that work that's done at night, or the work that's done on an email with the patient that's a little bit more challenging to capture. And we try to structure the evaluation and management codes to capture that work from both a medical decision-making perspective or from a time perspective. But to your question, yeah, I think the opportunity is to making sure that fee-for-service and the description, the nomenclature that comes out of current procedural terminology is accurate, because even though that informs claims and billing, it also informs epidemiology, health policy research, resource use determination, even budgeting for institutions. We have to have a consistent language to describe what physicians and ultimately their teams are doing. Thank you.
Great. This is an area that the Centers for Medicare and Medicaid Services has also thought a lot about. And Purva, you specifically in your role as Chief Strategy Officer at the CMS Innovation Center, can you share a little bit about hybrid payments, certainly, but also other value-based care payment models that you have worked on or that have been put in place to try to get at this crux of under-resourced primary care?
Yeah, I'm happy to. Primary care was really the cornerstone of the 2030 vision to bring what we were calling accountable care to all Medicare beneficiaries. And I think you hit on a really important word, like longitudinal, right? You have a relationship with this patient for 20 years, 30 years, and that's a longitudinal relationship. And when people are engaged in those kinds of primary care-based relationships, you're able to get them the care they need over the course of their lifespan. Dr. Miller also talked a little bit about the role that Medicare plays in setting the standard for other payers. And so we knew if we sent a market signal like that out, that we want all of our beneficiaries in that kind of a primary care-based relationship wherever it makes sense, that hopefully other payers would also follow suit, that this is where we want the system to be headed. So that was sort of the big picture vision. You can't get there without primary care. We also know that's the key to improving health outcomes, building a more sustainable health system. I think we had the advantage when we started in 2021 that that kind of vision was the culmination of a decade of testing. MedPAC did work. The Innovation Center had previous models as well. And there's a lot of expert input and a lot of bipartisan input into that vision that this is really where we're ready to kind of take this next step and make this the next goal. And so we built a primary care strategy around 3 key pieces, some of which you all have hit on. The first is investment, right? You can't do more with the same dollars. It's not rearranging the deck chairs into a hybrid payment, but it is increasing the actual payment levels and then changing the structure of the payment. We did that in many ways through state-based models, standalone primary care models, and ACO models, knowing that practices sit in different places. Now, I would say the one place where you're a little bit limited is, what the inputs into that hybrid payment are driven by the valuation of the codes, right? And we talked about that in the previous panel or discussion, and that's why it's so essential that we do these things together, that we actually reevaluate the actual services themselves. The second was an understanding that not all patients are the same and that we have providers that are caring for underserved communities that have more complex patients, and that in those payments we need to be able to take that into account. We really need to be able to provide additional dollars and payments to those clinicians that are caring for more complex populations, to be able to address things like health-related social needs, again, help people navigate their changing needs, and that's often the role that the primary care provider plays, and a real emphasis on bringing safety net providers and federally qualified health centers into models, because they are providing a lot of the primary care in this country. And then the last was permanence. I think somebody here also you talked about permanence. And if you're going to make these investments, you're going to participate in these demonstrations, these models, you want to know that there is a path to permanency. And there were 2 ways that we were approaching that. One was multi-payer alignment. Again, if Medicare sends that market signal, can we get other payers to align? And we know that's especially important in primary care, where your average practice is dealing with 6, 7, 8 different payers. And if we can get enough of a book of business aligned, directionally aligned, does that make it easier for practices? But then there's also permanency in the Medicare program, and that's a lot of the work that we had started last year with our colleagues in the Center for Medicare to start to think about, is there a possibility to have some version of a hybrid payment, in the future in the fee schedule? And there was a request for information out about that last year. But that was sort of how we were approaching it. How do you take these, all of these learnings, all of this evidence that's being created not only within CMS but externally to move the system in that direction?
One of the things that we often hear with respect to value-based care is that we need to move off this fee-for-service chassis. But I think that the truth is that many of our current value-based care models are sort of built on top of the fee-for-service chassis. And so we are supplementing fee-for-service in the ways that you just described, but we are inherently still tied to it. And I think that's why we have heard a lot about the need for updates for physician payments at fee-for-service, even in the value-based care space, because those fee-for-service payments sort of serve as the foundation. How did you think, Purva, about really leveraging that chassis? I know there were some models at the Innovation Center. For example, ACO Reach used a rate book. There are other models that were built off of just the sort of the more traditional fee-for-service chassis. How did you think about balancing innovations across those two approaches?
That's a good question. I think the other one I would point to is the ACO primary care flex model, which multiple people in this room have worked on and advocated for. But that's one where you're really trying to create a primary care rate book, knowing that we can't control the reevaluation of the codes themselves. But there are other inputs that we can use to start to try to break that link, hopefully, between fee-for-service valuation and more of a hybrid payment approach. I think ideally you'd have the 2 things moving hand in hand, so that you do have a body of experts and a general consensus on how to move forward. But those are some of the approaches that we've taken in the ACO space as a rate book, and that's tricky. It is hard to figure out what inputs, especially in a changing environment where you have practices using more virtual care capabilities. You've got telehealth, et cetera. Valuing those things in a really dynamic healthcare environment it's challenging and it's difficult. But those are some of the and when we think about a decade or more of testing, that's what it allows you to do, right? You start with like a PMPM payment approach and thinking back to like CPC and then CPC plus and then moving towards a rate book. Like these things evolve over time. But that's definitely part of what we were trying to do. And then you still have a lot of practices that aren't quite ready for that, right? And so hence the need for a making care primary and a standalone primary care model where you are continuing to help those practices that are not ready. They do not have the technological capability, the workforce capability, et cetera, to be able to accept those hybrid payments, work off of a rate book, et cetera. And I think we saw that with that model. It was smaller than we were expecting out of the gates, but over 40% of those participants were federally qualified health centers, and the majority of practices that came in were independent practices that had not been in a value-based payment program or model. So there's interest out there if we can create the right opportunity and pathway.
Creating a glide path, upfront investment, those kinds of things to get someone ready to go from 0 to 100. Miriam, I know you've looked at this issue internationally. Other countries, obviously people in other countries get primary care. Other countries have different models for paying for it. Can you say a little bit about international models and what they look like compared to our models?
Sure. I think we set out in our book, which is focused on Japan, Germany, and France, to look at fee-for-service systems with multi-payer structures. And we did that quite deliberately to try and find a comparison that we thought would be helpful for the US. And I think one of the takeaways of that analysis is that when you've got these systems where there's fee-for-service, you also need multi-stakeholder processes where there's more than just sort of one or two groups negotiating and setting those rates. I think that what is a real tradition in Europe and also in Japan, where I studied, is this tradition of getting people together and coordinating a common sort of strategy. So I think that's one thing that's really important. In France, they have really struggled with primary care as well, and so they've started doing practice-based payments. So we see a bit of a convergence over this sort of hybrid model. But none of these countries struggle quite so much as the US in terms of those differences in compensation between specialty and primary care. And that's an important factor. In terms of also how these countries structure things, I think, I think there's great interest in what the private sector is doing, and so we need to be mindful of how hybrid payments might create new and perverse incentives in that area.
Great. I know you've also done some work on different types of investment models. So over the past few years, we've really seen a proliferation of different types of models for primary care. So we have seen more retail model primary care. We have seen more private equity investment in primary care. So a lot of different versions of primary care offered, particularly post-pandemic. Can you say a little bit about your work in that space and sort of how you think about the opportunities or maybe even new challenges created by some of these new and emerging types of models for bolstering primary care reimbursement and payment?
I think there's a real role for the private sector, and particularly encouraging kind of very consumer-oriented and consumer-responsive models of medical care. I think where it falls down is maybe, when people are a bit more complex than just sort of a simple problem. And that's where the sort of necessity of having a consistent provider is really important over the long term. I think also that what I discovered working on the issue of steward healthcare in the Senate was that there, ACOs became a sort of a tradable asset. And so if we incentivize or create new forms of care, we have to be really careful, especially if there's going to be big bonus payments or, large payments, to make sure that investment is sort of doesn't disappear in terms of being an investor return rather than following the patient. The money has to follow the patient. And so you can do that by putting limits on how long funds have to be held. There's a lot of options, but we definitely need to be attentive to those issues in the future.
One of the things I think that has come up across the panel, I've heard it mentioned a few different times now, is the importance of multi-payer models. And you can look at that several different ways. One way to look at it is that it benefits the provider because they, adopt a practice or an intervention, let's say doing annual wellness visits, and they just do it across their panel. It's standardized care, becomes part of their routine practice, no matter what type of insurance the patient has. Another way to look at it is to, think that it's important to have multi-payer models, because if Medicaid reimbursement is low, for example, or Medicare reimbursement is low, perhaps commercial reimbursement will be high, and then it will all balance things out. That, of course, is sort of masking the underlying problem of the low reimbursement in the first place. So I'm going to just throw this open to the whole panel to talk a little bit about considerations with respect to multi-payer models. Do multi-payer models sort of obviate the need for payment reform for some of these systems that have lower payment rates? Do we still need, reform or adjustment for some of those markets that might be lagging a little bit behind? How should we think about multi-payer models?
I'll start out as a clinician. So, my practice in Virginia, I think we have 60 some different insurance products, and everyone's got a different set of quality measures. We mapped it out. There's like 120 different variations of the quality measures that we have to do for quality payments and things. And it gets really hard to organize care because we're trying to meet a million benchmarks and they're all conflicting. And then trying to say, well, you have this payer, so I can give you this, but you don't, so I can't give you that. So I look at like the advanced primary care management payment. We're still struggling with how do we do that for traditional Medicare versus the managed Medicare, where it's not supposed to apply to yet. Does that mean we don't give that service to our managed Medicare patients, or we do? And as a family doc, I just want to ground it in the essentials of, well, what's important about being a good family physician? The continuity, the quality, continuous longitudinal relationship, the comprehensive whole person-based care. On one sense, it makes sense to just say, well, why don't we just make the agreement around what we think good primary care is and try and create those standards and those alignments. And if you think of primary care as a system, you need to be able to implement the same system for folks across the board if you want to do it well and do it consistently.
Yeah, and just to include an example there. So one of the requirements of that advanced primary care management bundle is a 24-hour nurse hotline. You, as a physician, want to make that available to all your patients, not just a special secret number that the Medicare fee-for-service beneficiaries call. And that makes good clinical sense as well. To being aligned with the payment policy.
Yeah, we wouldn't stop doing that.
Yeah.
So that's something we've always done. And so, but that's the thing about trying to figure out. It's also not fair to say, well, Medicare alone should fund that resource. That's not right either. If you just think even from a market standpoint, all payers who derive that benefit should be participating in resourcing that.
Other thoughts on Miriam?
Yeah, I think that it's really important that we start thinking about multi-payer models and that we also think about bringing together the public and private sector to talk about these things and have a coordinated approach. Perhaps, bringing the private payers to the table and saying, what does primary care look like when we take a system-wide perspective? That's how other countries do it. They do not have these silos. And Medicaid is part of that. I feel bad being a Medicare focused. I don't pay much attention to Medicaid, but that's vital. And yes, we don't control what states do. Every state does things slightly differently. But we can really kind of try to work together and have a more coordinated approach, I think.
Go ahead.
I defer to these experts on the models we're describing, but I just want to reemphasize a point I made earlier is, as you think about the consistency that Dr. Krist just described that would make his practice more productive and make his joy as a physician greater, I mean, the consistent nomenclature to describe across multiple payers what's being done is so relevant. And that's certainly Category 1 CPT codes for the services physicians provide, but it's Category 2 codes around quality. It's consistent codes within what used to be PQRI, now is the PQRS, now it's MIPS and all these different quality programs. And that's something the AMA is really focused on, which is making sure that the nomenclature is meaningful and it's representative, and that it evolves in a way that allows physicians to do exactly what Dr. Krist was describing.
Go ahead.
I was kind of, when I think about multi-payer models, I really think about it from the provider perspective, that this is really about making it easier for providers to be able to participate in these programs and these payment structures, make it more sustainable. I think in the end, it will also make it easier for payers, right? It brings some efficiency into the system. I do not think about it as a way of making up for potentially lower payment rates in Medicare or Medicaid. I think that's just a structural issue that has to be addressed regardless of whether we're taking a multi-payer approach or not.
Great. So we're going to end with a sort of a round robin wish list. If there was one thing you could ask for Congress or the administration to do on physician pay, what would you ask? And I have to point out, being that we are in Washington, D.C., that today the House of Representatives is planning to vote on a government funding package that does not include physician payment reform. There are some promises about addressing it down the road, but the package currently in front of Congress does not include physician pay. So no immediate relief on some of these challenges. So with sort of that backdrop and framework, I couldn't skip saying that. I'm going to ask our panel to sort of weigh in on where they think Congress and the administration could be most impactful. So I'll start here with you, Dr. Krist.
I couldn't get it to one. I got two. I
Okay,
apologize.
I'll allow it.
They're simple. One is, I do think supporting this advanced primary care management payment as a pathway, and it's going to be a journey for both clinicians and CMS and others and health systems. And the second one is I think we need to invest in truly valuing what it costs to resource and deliver primary care. We have technology to do this now with natural language models and AI and our electronic health records. We actually can see all these touches. We haven't really invested in this, and figuring this out, I think, would move health forward a lot for the nation.
Mm-hmm.
I'm just going to plus one to what Dr. Krist said. I was thinking I had two things too. Number one is creating a permanent advanced primary care management or hybrid payment option in the Medicare program. I think that gives people the permanence and certainty. I think it restructures at a baseline how primary care is paid, and coming at it from a CMMI perspective, it gives the Innovation Center something to innovate into, right? Similar to how we do our ACO work. So I think that would be great. And then number two is, but to be able to get those numbers right, can we also start really augmenting and looking at new data sources to inform the work of the RUC and others and CMS.
It's possible that what we need to think about also is a separate kind of stream of funding, or some way to ensure that those resources are there for primary care. I remember in the I don't remember, but in the 1990s, there were separate conversion factors for different services. Now, some people say that's really difficult to do. There's pitfalls with that, but the idea that we have some sort of dedicated funding for primary care could be something that we should think about, and also as part of that, kind of rethinking what is the work. What do primary care physicians do? How does that work valuation? What does it mean to value the work of primary care? And I think in some ways, and it's not the RUC didn't write the legislation, but the valuation of work, the definitions, need some sort of calibrating and rethinking.
Great. Dr. Silva.
Miriam's point is really important. We had a service a while back where the specialty said, well, let's change the definition of work. And our response was, we can't do that. That's in statute, that's in regulation. It's just not physically possible at this moment in time. So I love that point, and I agree. I agree with every point made about the importance of primary care and the innovation that's described. In answer to your question, and Mark Miller mentioned this, we need more money. I mean, you need more funding for these initiatives. One way to achieve that is to rebalance the system, take from some and give to others. The other way to solve that problem is to bring in new money. Physician payments have decreased by 33% since the year 2000. During that same period, practice costs have gone up based on the MEI by about 20%. At the RUC, when we value services in the office setting, practice expense, CMS pays less than 50% of those direct expenses. I mean, that's gloves, that's staff, that's equipment, that's everything that we need to do as physicians. And the only way to find a gap to solve that problem is to bring money from the general treasury into physician services and to do so responsibly. Thank you.
Great. Thank you for having us. I think that concludes our panel, and I'll turn it back over to Sean.